All right, thank you, and good morning, everyone. My name is Bob Jasak. I'm with Heart Health Strategies, and we're based in D.C. We work with AGA and a lot of other organizations exclusively on healthcare in the regulatory and legislative realm. And what I wanted to do today was lay the groundwork for our first discussion about all of the changes that we know are coming in Medicare payments. And obviously, that's going to have a spillover effect into other payment, into other payers and how they pay. So what we're going to do is try and break down what the changes are going to look like, and in the areas where we don't know the answers, what can we use as lessons from Medicare's past approaches to try and inform where we might be headed. We are going to have a panel after this where we can get into a more in-depth discussion about the different pathways that you might want to look at investing in as we're going through the transition in the payment system. So we can definitely take questions there, but I know that a lot of this starts to get a little complicated, so feel free at any point to interrupt me as well, and I'm happy to answer questions as we move through. So what we're going to do is break this into three sections. And one, we're going to say goodbye to the sustainable growth rate formula, or the SGR, and talk about how that happened and what it means in the short term. And then we're going to talk a little bit about what it means, what the future of the physician quality reporting system looks like, or Pqrs, at least to the extent that we can guess. And then finally, we're going to talk about living under the value-based payment modifier. And again, this is where Medicare has really made an investment in its pay-for-performance program. And so what can we learn from that as it exists now, and what are your requirements going to be over the next year until we start to transition to the new system? So with that, the big shift came last year in 2015. We know we went year after year after year trying to patch the SGR cuts that were coming. They were always hanging over your head, 20%. And so the last patch had expired on April 1st, and then Congress finally decided to get rid of this once and for all. So Congress passed the Medicare Access and Chip Reauthorization Act of 2015, or MACRA, which is the new acronym that you're going to be hearing a lot for a long time to come. That was signed into law on April 16th. And basically, there's a lot that was in the law, but from a payment perspective, there are two big things that happened before we get to the transition. One, it obviously got rid of the SGR, which is a good thing. The other thing, and this was really driven by the physician community when Congress was working on the bill, was it creates a period of stability in Medicare payments. At least that's what it's referred to. And so what that means is over the next few years, there's going to be a base update of 0.5% built into your Medicare payments year over year. What you can see here is that takes us through 2019. Just one thing I want to point out is that the percentages that we're talking about here, this is essentially an update to the conversion factor. So the conversion factor is going to get a 0.5% bump. The second thing I want to mention, though, is that this is not the only thing that affects the conversion factor. So you can't just take the conversion factor and compound it out 0.5% over the next few years, because there's lots of other things that go into what that conversion factor is going to be, whether it's budget neutrality. So you can't guarantee that it's going to go up, but this is at least a cushion that's built into how they're going to calculate the Medicare conversion factor. There's a lot happening here, but this is essentially the timeline of what Medicare payment's going to look like, and I just want to sort of focus you in on sections of it. So that period of stability that I was talking about was what you see in this box here, and that takes us through 2019. What you see in those boxes underneath it is that the EHR incentive program continues as it has been under law, Pqrs continues as it has been under law, and the value-based payment modifier continues. The new world, though, is what starts in 2019, and that's this era that you see here. We're going to walk through what those different cells on this table are starting to mean, at least to the extent that we know so far. But you can see that there's a little bit of overlap there. The one other thing I wanted to mention, because you probably hear the year 2019 thrown around a lot, because that is when the new payment updates start, that 2019 is when the payment updates will be implemented. That doesn't necessarily mean mean that your reporting requirements aren't going to start until 2019. So just like PQRS, it's expected that your performance will be assessed 2 years before. And so what we're looking at is this being sort of the last reporting year for PQRS as it exists and shifting to something new next year, although we haven't seen the new rules, so I can't guarantee all of that, but that's the expectation. So we're already really close to this new world that you see at the bottom right. So I want to just spend a few minutes talking about that new world and try to break it down, and then what we'll do is sort of lift up. I'll answer any questions that I might be able to, and then we'll dig into sort of what we know about the programs as they exist and where we can use that information to try and figure out where we're headed. So again, 2019 going forward is the new era that we're talking about. You're going to have that base update to your conversion factor of 0.5% the first year of the transition, and then that base update will turn into a 0% base update, and then your payments will be updated one of two ways. It'll either be updated based on the merit-based incentive payment system, which is MIPS, or it will be updated based on your participation in alternative payment models. So I want to walk through these a little bit, what the contours of them are, but for the most part, what you can, when you're thinking about these, they're mutually exclusive. Your payments are going to be updated really one way or the other. Which category you fall into is going to, we're not quite sure yet, and there are rules that we're waiting for, and hopefully we'll hear more about that on the panel, but we will, this is basically the two ways that your payments are going to start getting updated now. So for the merit-based incentive payment system, think of this as sort of a reshuffling of the programs that already exist and sort of spiced up with a couple of new concepts. So you're going to, payment updates are going to be based on evaluation on 4 different categories. So one of those categories we're already familiar with, which is quality. So that's like looking at the PQRS system and the value-based payment modifier, the quality aspects of that. EHR meaningful use is a separate category. There's a lot of information coming out of the Department of Health and Human Services about how the meaningful use program is going to change drastically for physicians, and how that participation and what the requirements are going to look like, we have to wait and see. And then the second thing we need to see is how your performance in that is going to translate into a score for purposes of your payment update. So that's a world where there's a category where there's a lot of question marks. The two other areas that are added in are resource use, and really there's a greater emphasis that's going to be placed on resource use in terms of calculating your payment updates. And then the last, which is the most novel, are clinical practice improvement activities. And I'm going to talk a little bit more about that on the next slide, so I'll describe that more then. But essentially what's going to happen is, we don't know the exact methodology yet, but you're going to be evaluated in these 4 different areas. They're going to be weighted differently, and those weights change a little bit over the first couple of years, which is why I didn't put the weights on the slide. Those are going to give you a score of somewhere between 0 and 100, and that's going to lead to a payment update, and the range of sort of risks and rewards that you're subjected to changes by year. So you can see in 2019, the range is essentially plus or minus 4%, and you can see the stakes growing as we move along the timeline. One thing I'll say is that there's additional money that was in MACRA for extraordinary performers, and so there is a chance that the upside could go a little higher than that. But I think the safest thing to do is expect that those are about going to be the ranges. I'll mention, and I'll show you a slide on this when we get closer to the end. In terms of sort of, moving from the SGR to this system, is that you'll see is that there's actually the potential for bonuses now when you look here. And a lot of the programs, EHR meaningful use, PQRS, they were shifting into penalty only phase. And so this is at the outset limiting your risk and also adding an upside that wasn't previously there. I mentioned that the clinical practice improvement activities category. I just wanted to spend a second on that again because I think it's one of the more novel concepts that's incorporated into this. So previously, your payments were updated based on claims-based measures. You're reporting into PQRS. but there wasn't anything that took into account the activities you engaged in to improve quality, either on the local level or in a lot of other ways that you spend your time that does lead to better quality and reduce costs. And so the law built in this performance category of clinical practice improvement activities to try and take that into account. So the law mentioned a couple of different specific subcategories that are in here. So things like expanded practice access. So that could be after-hours appointments, same-day appointments. You can also see beneficiary engagement, so establishment of care plans, shared decision-making, and then patient safety and practice assessment. So you can see checklists are on there, but and again, we don't know what the final rule is going to look like on all of these, but these are the things that are under consideration. And it includes things like maintenance of certification. So things that you may already have to be doing anyway, starting to get credit for that and harness it so that it contributes to your payment update. So a lot of questions still out there about what will be approved as one of these activities, and also how CMS will be able to verify that you actually engaged in it, and how that would be reported. But again, something else to consider here about how payments are going to change in the future. The second option that I had mentioned is the alternative payment model update, and that's structured a bit differently. So basically, if you are determined to be a qualifying participant in an eligible APM, you will get a 5% lump sum bonus on your Medicare payments. And you can see the bonus payment for APM participation stretches through these years here. And a couple things that I want to mention about it. First of all, by definition, APMs are going to require providers to take on financial risk. So it's not necessarily just all upside. It's not that you just can bank on a 5% increase in your payments. That's really meant to be more a cushion. And then inside of the alternative payment model, you'll sort of live or die by whatever the risk sharing rules are inside of that. So we can't make any generalizations about how payments would necessarily pan out in those models, because they're all going to vary based on their various rules. But the idea here was to give an incentive to move into those models, and that's what that 5% lump sum bonus is intended to do. The other question mark here that is going to inform how many people are really eligible for this kind of a payment update, and I've got a couple slides on this as well, but I'll mention it here, is that the law requires you to deliver a certain percentage of your services in the context of that alternative payment model to qualify. And so when we're thinking about alternative payment models, and we can talk about this more on the panel about how these might be structured, it's not just whether you're participating in an alternative payment model, but it's, are you doing enough of your entire portfolio inside that to qualify for this? I'll give you just an example. If you think about one of the easiest ones to think about is sort of an ACO. So if you're affiliated with two hospitals, one's structured as an ACO, one is not, only those services that you deliver in conjunction with the health system that's part of the ACO are going to count. So could lead to practice shifts. It could, in order to qualify for that, there are a lot of questions we don't know. But if you also think about bundled payments, same sort of thing. Are the services you deliver in the context of those bundles going to get you to those revenue thresholds to qualify for this? So again, something to keep thinking about. What are the APMs that are going to be out there? The law mentions the CMMI models, Medicare Shared Savings Program, which are the Medicare ACOs. But it also says that to qualify for these APMs that you have to be doing it in the context of an eligible APM. And in order to be eligible, it has to have quality measures that are comparable to MIPS. You have to be using a certified EHR technology, so not necessarily meeting the meaningful use criteria, but utilizing certified EHR technology. And then finally, that you bear more than nominal financial risk. And there's one of the ways to get out of that is have something that's comparable to a CMMI medical home, but for the most part, they're required to bear risk. The provider's got to bear risk. And so we've already heard a couple of signals from CMS, and again, maybe we'll talk more about this later. But they've essentially said that there are some models that are in the Medicare Shared Savings Program as ACOs that don't require the physicians themselves to carry any of the risk. And they're saying that those types of models wouldn't be eligible for this type of payment because the provider isn't taking any risk. So the way that the rules come out on that are going to be really important, and trying to structure APMs, and when you're making investments and building them, knowing the contours of this are going to be incredibly important, because there are going to be some nuances to what gets you credit under this category and where you don't. These are those revenue thresholds that I was talking about. So again, you've got to be in an eligible APM, and then you've got to qualify. So to qualify, a certain percentage of your services need to be delivered in the context of an APM. So if you look at the Medicare only column, we'll just start there. The first 2 years, they're only going to look at Medicare eligible APMs. The first 2 years, you have to have at least 25% of your revenues in the context of an eligible APM. That starts to go up as time goes on. If you look a little bit further to the right there, you can see the combination Medicare all-payer eligibility numbers. So starting in 2021, if you're a little more heavily skewed toward commercial payers, and you're affiliated with eligible APMs that are associated with those payers, you might be able to qualify for this bonus that way. Still questions about how are we going to know which private pay APMs are going to be a part of this? Are they going to have to affirmatively apply? Who's going to give them the stamp of approval? There are a lot of those questions, but the law outlines a way to qualify for the APM bonus payment by looking at not what just what you do in Medicare, but other payers as well, and including Medicaid. Here's another chart. I don't want to make this too confusing, but there's another concept in the law that's called a partially qualifying APM participant. And I just wanted to point that out because you might be hearing it a lot. And if you are determined to be a partially qualifying APM participant, you're actually not eligible for that bonus at all. What it does give you is the option to avoid doing MIPS. And essentially the theory here is to build in a bit of a safety net. So if you really try and go for that APM bonus and really make a bona fide investment of it, but fall short of those revenue thresholds, there's sort of this, hold harmless area in the middle. And if you were to fall below these thresholds, you may still get some benefit from trying to participate in an alternative payment model, because in that performance category that I mentioned, the clinical practice improvement activities, there's an explicit direction in the law to make sure that people get credit for those clinical practice improvement activities if they're participating in an APM. So I just wanted to mention that here, because even though it sounds like it, partially qualifying APM participant might mean you're getting a lower percentage of that bonus. It's not that at all. You can't get the bonus if you don't meet the qualification thresholds, but you can be held harmless from having to participate in MIPS. All right, let's skip this slide here. So again, we're back to this to the timeline. As I mentioned before, those payment updates are slated for 2019, but we're waiting to see what the performance periods and assessment periods are going to be for those payment updates. And that leaves us still in this category here, or this period of time here. As we know from the programs as they exist, that right now reporting that you're doing into Pqrs and for purposes of the value-based payment modifier are dictating what's going to happen in 2018. So we're at sort of the last year inside this box that I have highlighted here. And so what I wanted to do next is talk a little bit more about what the requirements look like right now, but also sort of look at your reporting options and see what we can glean from how those reporting options have been discussed by Medicare to figure out, one, what might be carried over, but also, two, what you have to do over the course of the next year before these new systems start. So with that, I'm going to pause for a minute to see if there's any questions, because I know that's a lot of initial information.
So when you say hold harmless, you can be 0% with the potential to make something related to the clinical. I
probably shouldn't have used that word. Basically, what it's sort of it's sort of an in-between world where you will not be eligible for the APM update, but you're also not responsible to pay for it, or not responsible to report into MIPS. So it is essentially zero, but you're just kind of not in either, your foot's not in either of those buckets. That being said, my understanding is that if you are partially qualifying, that while you're not required to participate in MIPS, because there are bonuses that are associated, that you can opt to continue to report in it. So you wouldn't be prevented from reporting into MIPS if you wanted to. Yep.
So some of the quality reporting is group specific and some is individual physician specific. Is the percentage of participation going to be group specific or is it going to be individual physician specific?
The question was, since so much of this is reported via a group, will the updates be administered via a group or the individual? I want to be careful about how I phrase this. My guess is that it will be either. It will be administered based on whatever the reporting entity is, sort of the way that the value-based payment modifier now is administered by TIN. That being said, there are nuances in the law about creating new types of reporting entities, virtual groups, or also trying to figure out whether an individual payment update should be applied to just you based on all of your services, regardless of how many TINs you're reporting under. So I think there are some questions to it, but I think the theory is that there will at least be a mechanism for group reporting, and then the payment would be administered that way. But the part of the language in the law sort of tries to make it sound like each individual should have a score to know how they've done over the course of the year, and I think that could have implications for how the payment's administered.
Question: Can a clinical integration network serve as a vehicle for an APM?
I don't know. That would be a great question for our CMS panelist after this. What's going to qualify for an APM is one of the big things that we're waiting to see, and I don't know the answer. Yep.
In qualifying for the APM, so I'm assuming it's not a 5% increase annually, right? It's a 5% one time.
You get it's a lump sum bonus payment on the allowables for that year.
Okay.
Yeah.
But it's not that you can get 5%
Right.
each year.
Right.
And then once somebody theoretically qualifies to be in the APM world, what happens if they're in for 2 years and in their third year, the percentage of their payer mix changes and they would drop below threshold?
Yeah, so it's a great question. So if just in case anyone couldn't hear, the question was what happens if you were a qualifying APM participant, let's say for 2 years, and then in the third year, for whatever reason, you weren't, your payer mix changed or whatever it might be. The direct answer is at that point, you would be subject to MIPS, unless you were in that middle qualifying APM participant world when you missed the thresholds and you could opt out of MIPS. But the question there is, which is another reason we're waiting to see the rules, is if you are a qualifying APM participant, when are you going to be notified so that you know whether you have to meet the MIPS requirements or not? And so, one of the questions that I've asked when I've had conversations with folks at CMS is, let's just look at the first year. If 2019 is the first year for the APM update, are you going to know on January 1st, 2017, whether you have to report into MIPS? So my guess is the answer is no. And so I think the safest thing to do is probably going to make sure that you meet the MIPS requirements. But I think it's a big question because this is presented in so many different ways, including by the folks in Congress who wrote it, as sort of you have a choice. I'm not really sure choice is the word that I would use. I don't think you're going to sort of trip into an APM. You're going to know whether you're doing it, but you need that confidence that you qualify for the bonus so that you don't meet the MIPS you don't have to meet the MIPS requirements. And I don't know when you're going to be notified of that.
And not to be the cynic in the room.
Yep.
But and I've heard this from other providers who've had this conversation. Until these rules come out, and once the rules come out, the actual cost of participation, whether it be MIPS or APM, may easily exceed the potential upside, and may even actually be higher than the downside. And so there may be an opportunity here for a lot of practitioners to just say, I'm out.
Yeah,
You know, I'm not, it's cheaper to take the downside
right.
than it is to try to create the infrastructure to meet all those requirements. And I'm not trying to put you on the spot, I'm just saying there's a lot of discussion going on out there that just sounds almost as crazy as SGR.
Yeah. Well, and I think that there have been a lot of discussions like that along the way too, especially when you were looking at Pqrs and it was a 0.5% bonus opportunity. I've seen people who've gotten checks for Pqrs that qualified for the bonus, and it was $1.50. And so, so I think that, but those are, those are business decisions. I think, the theory here, remember the timeline where those numbers start to go up. And so that changes sort of the cost-benefit analysis, but I hear you, yeah, we've heard that.
I have one last question. And it's maybe for the CMS people, but is there any thought, because a lot of the times, like in PQRS, what they apply to the general physician population in primary care, we try to apply to subspecialty care, and it doesn't necessarily really affect our quality or our outcomes. The 75% mark may be a really good number when you're looking at population health in the primary care field, but not necessarily a reality when you're trying to do the same thing in subspecialty care, and that number should probably be a lot lower to reach the thresholds. Has there been any talk to look at that?
I think that's been a constant concern that's been expressed about trying to make sure that measurement is reflective of the care that you're delivering. I think in terms of implementation, part of how that will manifest is a question about the requirement that the providers take on nominal financial risk and that they're reporting on measures. So if you think about the group practice reporting option now, there are probably a lot of you who are participating in PQRS via that option, but the measures that are being reported on don't have anything to do with your services. It has to do with other people that are in your group practice. And so the question is, sort of in the APM world, is when it gets to risk, when it gets to measure reporting, is every single person in that APM going to have to do that, or will just some of them? And then for the folks who don't have measures that exist in that APM, will they be able to still be eligible for the bonus? So I think that part of it's a semantics question. I do think that CMS has been trying to have discussions to make sure that measures are available for everybody. But when you get to the point where there's going to be a proliferation, hopefully, of APMs, their ability to engage on that is going to be diminished because they don't build all of those APMs. So
I'm just curious. I think I know the answer to this, and you already said the words hold harmless. Hold harmless to MIPS and subject to MIPS. It infers to me that may MIPS be a less desirable alternative, or we just don't know yet until the final rules?
I don't think we know, and I'm not sure we can ever answer that, just because there will be so many different APMs out there that it's gonna just sort of be practice by practice deciding what the options are. Yep. No, go ahead.
Just a clarifying question. So if you do qualify to be an APM, your bonus would be 5% every year, assuming you qualify, correct? So it would be based on your previous, or if it's still PQRS, it would be based on reporting. Say 2019 would be based on reporting from 2017.
So in APMs, I'm not sure.
We're not sure yet.
Yeah, we're not sure. There is language in there, which again, I don't want to get too tripped up into the details, but there is language in there that has led some people to believe that when it comes to the first year of the APM bonus, that they're going to look at what's delivered in 2019 and cut you a check in 2020. But this goes back to what we were talking about before. If that's the case, how are you going to know in 2017 whether you met those 2019 revenue thresholds? So you may have to report into MIPS in 2017 because you don't know if you're going to meet the APM threshold, but then you do meet the APM threshold. All of that MIPS reporting was for naught so that you could get the 5% bonus in 2020. But I think that CMS is trying to align that more, but we'll see.
So what you're saying is theoretically you could qualify, but it'll be based on whether or not you actually qualify to be an APM year over year and meet all the other requirements.
I think so, yeah, and that the APM maintains its eligibility for this, and then you qualify by meeting the revenue thresholds. But yeah.
I mean, obviously, this is a Medicare-based program,
Right.
but you also mentioned that there's some opportunity to have a mix of different payers and still be underneath, either the APM or MIPS. I was wondering if if you look at three different types of practices, 100% Medicare, another, you've got 50% Medicaid, 50% Medicare, another all Medicaid. Like, what's the impact of this program on all different practices? Does the Medicaid practice now have any impact?
So when I talk about the bonus payments or the penalties, regardless of how you report, but the administration of the actual check, that is only multiplied by your Medicare dollars. So no matter whether you are qualifying because of a commercial pay APM, your bonus is still only on the Medicare dollars. And so the same thing. There could be Medicaid APMs that help you to qualify, but your bonus would still only be on Medicare dollars. The difference that I would say, though, is that there are different ways to report into the system. And even though the bonuses will only apply to Medicare claims, that the care that you deliver in Medicaid could help you or hurt you when it comes to the calculation of this. And what we're going to do now is sort of walk through reporting options as they exist, and I can show you where non-Medicare quality reporting could come into play. And I don't know that it will translate into this new system, but that's the way that it could be incorporated. Yep. All right, we'll keep moving. All right, so let's take a look at Pqrs and try and understand, one, the requirements over the next year, and then two, what we can learn about where we might go. And, just common sense, I think, tells all of us that all this time that CMS has spent building these programs, they're not just going to completely scrap them. And the law doesn't require them to either. And so, I don't think, especially in this first year, that it will be a completely different world. The way they calculate the payments will be, because that's what's mandated, but the actual reporting mechanisms is not likely to be. So right now, as we talked about, your payments are updated in a couple of different ways. SGR used to be involved, it's not anymore, but your payments could go down based on Pqrs reporting and performance, EHR meaningful use participation, and the physician value-based payment modifier. I put this up here too just to highlight the point that all of these programs here could make your payments go up or down. And so there are a lot of practices that I've spoken to who have said, we actually don't know what we netted because we're getting penalized over here, we're getting bonuses over here. And so that's one of the things that's changing, is that even though these programs or the benchmarks that you're going to be measured on are going to be similar to what's being used, they're all going to funnel into a single score and payment update. So it'll be a little bit easier to, I think, see sort of how you performed and whether on, overall, it was sort of a good year or a bad year, and also where your opportunities for improvement are. I want to spend a little bit of time talking about the Pqrs and the physician value-based payment modifier boxes, though, because those are I think we can take more lessons from the way they exist now. Meaningful use is its whole world, and we also know that that's fundamentally changing, so we won't spend a ton of time on that. This graphic I've shown to some of you that I've met with before, but I wanted to put it up here again just to put a little bit of context around how these programs are structured, but also to boil it down so that you can focus on sort of what does this mean to me in terms of how I need to report and how I need to engage on these Medicare programs. First thing that we haven't talked about yet is Physician Compare, and this is obviously Medicare's version of public reporting. Physician Compare is going to continue to exist. MACRA mentions it, so it's not going anywhere. So that's their public reporting mechanism. Then right now what we have is the value-based payment modifier, and this is Medicare's version of pay for performance. So not just whether you reported, but how did you do on those measures that you reported. What I want to mention here, though, is that how you're portrayed on Physician Compare, how you fare in the value-based payment modifier is essentially hinged on how you participate in Pqrs. So there's lots of reading that you can do out there about those other programs, but in theory, the best way to sort of affect your outcome in those is to be successful in reporting into Pqrs. So if you don't have a ton of time to dedicate to this stuff, focus on the Pqrs piece, because that's where you can really make a difference here. And when it comes to that, the question for you is, how are you going to report into Pqrs? So there's claims reporting, there's EHRs, there's registries, and there's qualified clinical data registries. So what I'm going to do is just do a slide that talks a little bit about the basics of Pqrs right now, but what I want to do is walk through each of those reporting mechanisms so we can see where they are, what the likelihood of them continuing is, and help you sort of boil down what how you want to think about interfacing with Pqrs or whatever name it has in the future. So as I mentioned previously, Pqrs is a penalty-only program now, and we are essentially in 2018 based on what you report this year in 2016. The 2016 updates are already determined based on what you reported in 2014. Just want to remember that in Pqrs, it's a specific set of quality measure, a specific set of measures, and a lot of specialties still have a limited set of measures available to them for reporting. In terms of participation, the last participation, or most recent participation data we have is for 2013. So across all of Medicare, about 59.1% of eligible professionals participated, and you can see in gastroenterology, it's higher than that at 64.6%. So doing a little bit better than physicians overall. In terms of who was eligible for the bonus in the last year there of bonus eligibility in gastroenterology, it was 48.9%. And the average bonus you can see there was $630, which again goes to sort of the cost of reporting versus the benefit that's available.
Does anybody look at what it costs the practice to report Pqrs data?
I haven't heard anyone look specifically at that, but I'm sure it's out there.
It's got to be more than $630 a person.
I'm sure. Yeah. The other thing to mention here are the requirements. And again, one, remember these are the reporting requirements for this year, but also we want to look at how they might change going forward. So there's starting to be an emphasis on moving from process measures to outcome measures. There is a concept known as a measures group, which we're going to talk a little bit more about in a minute. The nice thing about that is it only requires you to report on 20 patients, but there are limited options for using those measures groups going forward. So at the very bottom of the slide, sort of the baseline reporting requirements to keep in mind is that you have to report on 9 individual measures across 3 national quality strategy domains, which we'll talk about, on 50% of the eligible patients. And so, again, that's sort of where you want to think about where you are now, but also we want to look at, is that going to change when we move into the system that for the quality reporting piece of MIPS. Here, I just wanted to show you the top 5 most reported measures in Pqrs in gastroenterology, again, from that 2013 report. One of you can see some of them are a little general. The other thing I would just mention is that you're at least in a good situation because there's a lot of folks that I work with. I'll look at this list, and the measures that were their top 5 most reported have all been eliminated. So at least these are still around. But you can just get a sense of what people are reporting. And again, you can see, some of them are pretty general. So it's the tobacco use measure, it's the BMI measure, but the cancer screening, colorectal cancer screening is number 2. Also, CMS has been working with the specialties to create a list of core measures to try and identify whether there are actually measures to be reported that are specific to your specialty. And you can see here, and this was done in consultation with AGA, you can see the measures that are on that list. Again, they've got, since I mentioned that requirement that you have to cross 3 of the national quality strategy domains, that's the color coding you can see here. You can see the domains over at the right. So, if you were able to report on all of these measures, you would meet that national quality strategy domain requirement because there's 1, 2, 3, 4, 5 on your list. So As I said before, what I wanted to do was walk through those reporting options and talk a little bit about the pros and cons and also about the likelihood that they might exist going forward. So I want to start with claims. This is where Pqrs started. You would sort of put down on your claim form, I did what I was supposed to do, I didn't do what I was supposed to do, or I didn't do it and I had a good reason, and that would go on your claim. A couple things to mention about that. You're obviously going to be limited to process measures. So as we move further toward outcome measures, it's going to be really hard to use claims as a reporting option because you can't put a 30-day outcome on your claim form. There's obviously administrative burden that's attached to this. The measures group concept that I had mentioned before, CMS eliminated this as claims as a reporting option for those measures groups in 2014, and they've been pretty explicit in the fee schedule proposed rules about wanting to eliminate this as an option. They didn't eliminate it over the last 2 years, even though it was discussed. In 2013, about 36.8% of gastroenterologists used the claims reporting option to participate in Pqrs. But that being said, again, if you're trying to figure out sort of where you might want to make your investments or think about a reporting strategy, I would put this really low on the list. And again, that sort of goes into the writing that seems to be on the wall from CMS about whether to preserve this as a reporting option. The second vehicle I wanted to mention was reporting via EHRs, and this is different from the EHR Meaningful Use Incentive Program, but it's literally using your EHR to report your Pqrs measures. Couple things to mention about that. You obviously could have a lower administrative burden, but you've still got to report on those 9 measures on 50% of your patients. Last year there was only about 62 measures that were available via this reporting option. CMS has made an effort to align this with the clinical quality measures that are reported in the Meaningful Use Program. So measures that are available in both programs can be reported into Pqrs. The thing you just want to remember about that is that you still have to meet the Pqrs reporting requirements. So if you only have to report, let's say, for 90 days in meaningful use, that doesn't mean you only have to put in 90 days of data into Pqrs. So coordinating the reporting between those programs still can be tricky if you have those measures. In 2013, of all eligible gastroenterologists, only 5.7% use this. So there's 591 of them. And you can see that this is a pretty low utilization for the EHR reporting method, because that low rate of participation via EHRs made the top 10 specialties using that option. So it's still really low. So again, when we're thinking about where do I chart my path forward in this, this still is not utilized by a lot of people, and my guess is because of the quality measures that are available for reporting in there, that menu via EHRs is so small right now. So that leaves us with registries. Registries, there's the sort of straightforward Pqrs registry, and then there is what's called the Qualified Clinical Data Registry. So we're going to walk through those, and I'm going to show you the distinctions and give you a little, or at least try and read the crystal ball about where we see things headed here. So for Pqrs qualified registries, you can report individual measures, and that, again, is what we've been talking about with the 9 individual measures on 50% of your Medicare patients to which those measures apply. Those measures have to cut across the 3 national quality strategy domains, and at least one of them has to be a cross-cutting measure. And if you remember the top 5 measures that you reported in 2013, a lot of those were cross-cutting measures, so tobacco cessation, medication reconciliation, those are the types of measures that are the cross-cutting measures. But here's the reporting option where you get to report measures groups. So it's reporting on a measures group. And you have to report on 20 patients, and only 11 of those 20 have to be Medicare patients. This registry reporting option is the only mechanism for reporting measures groups going forward. The other thing that's beneficial about registry reporting is that the registries have time to collect data and send it to CMS. So they basically have until the first quarter of the following year to report it. So 2015 data could just now be reported. So, for a lot of folks, especially as you're doing, education across the membership, if someone sort of woke up late in the year and didn't do claims reporting along the way, that doesn't mean they're out of luck for that year, because you can submit data into these registries later, and they've got time to submit it to CMS for you to get credit. On gastroenterology in 2013, about 13.6% used the registry reporting mechanism, and 1,100 did it to report the individual measures, and 303 did it to report a measures group. Just to show you here what those measures groups can look like, you can see the IBD measures group that's right here, and the Hep C measures group is listed here. Now, I don't know, and I can't make a promise that this concept will continue to exist. One, we're obviously switching to a new system. The other is that 20-patient reporting burden is pretty low, and I don't know how long that will continue. But it's still something that exists this year, and so wanted to make sure we mentioned it today. Now, QCDRs, Qualified Clinical Data Registries, are not just intended to be a Pqrs reporting mechanism, but this is where they were created to be more of a quality improvement tool. So just a couple things about it. Again, you can participate via a group now. It used to be only individuals, but you can participate via a group, although it's at the discretion of the QCDR. And one of the big differences of QCDRs is where the measures can come from. So before, we had our standard set of Pqrs measures. In a QCDR, the QCDR can use Pqrs measures, but they can also incorporate the CAP survey, or they can use measures that are used by boards and specialty societies. So you have more of an option here to be measured on what matters for the care that you deliver. You still have to report on 9 measures that we talked about before, but one distinction here that I also wanted to mention is that 50% requirement is in there, but it's on 50% of all of your patients. So all of the patients who are eligible for that measure, you're required to report on. So it's not just your Medicare patients. So depending on what your mix is, there could be a higher administrative burden here in terms of reporting. There's an increased focus on outcome measures here. And QCDRs are required to give quarterly feedback reports. And the other thing that I would mention is that given that QCDRs are run by external entities, there were some questions about how public reporting was going to be incorporated into this. But it now is in 2016, Physician Compare is going to start including publicly reported information based on reporting in 2015. In terms of where we go from here with QCDRs, QCDRs are specifically mentioned in MACRA, so they are going to continue to be incorporated. And I think that there's a lot of opportunity here, again, because you have more control over what's measured. And the question is going to be, what will the reporting requirements be? Are they going to go up? What are they going to look like when you compare it to reporting via other mechanisms, the way that we just walked through the Pqrs reporting mechanisms? You can see the Digestive Health Recognition Program registry here as potential QCDRs going forward. And so, again, we want to keep an eye on the rules and what our options are. So, again, just to lift up, looking at this graphic that I had put up before, that Pqrs really is the hub. I think something like it will continue to be incorporated as we go forward. And so the question for you certainly this year is, how am I going to report into it? And then a lot of your sort of destiny in Physician Compare and the value-based modifier will flow from there. So I want to switch and talk a little bit about benchmarking and pay for performance in the way that value-based payment modifier has been structured. But before I do that, any additional questions? Yep.
I have a question. It looks like that you had it arranged from left to right, highest reporting burden to lowest reporting burden. I was struck when a number of folks in the audience said that $630 per patient wasn't enough to cover your reporting costs. That sounds like you're spending a lot of money out there. On what? What is it? I guess my question is, what are the dollars
So the one thing just to remember is that that was a 2013 bonus number, so that obviously could change. But that's total, $630 total. So when you look at a lot of the Pqrs registries or QCDRs, it completely varies, and a lot of it has to do with whether it's a specialty society and you're a member and you get a preferential rate. But for a lot of those registries, it can run to the upwards of $250 to $500 just to participate. Now, that's not the case across the board, but that's just one cost before you even get to staff time dedicated to pulling all this information together. So my guess is that's part of where that's coming from.
I was going to say the staff time is huge.
Yeah.
Nobody's in the HR does this automatically. So you can run your diagnostic code to find the subgroup of patients, but now somebody has to go through and say, they have hepatitis B vaccine or not? Were they hospitalized or not? Did they have a complication of steroids or not? We manually abstracting that data, which is just a huge amount of time. So even though it's 20 patients, it's literally hours per patient. You need staff time invested in pulling this data together.
And then you got to report it.
Now,
Report in a special fashion.
right. And maybe that equation starts to change when we look at, let's say, the first year of MIPS, and it's plus or minus 4%. And you're talking about 8% of your your revenues at stake. But yeah.
The other major issue here that adds complexity. I don't know whether you're going to be talking about it with a QRUR report, but all this quality reporting through PQRS drives your QRUR report, which then pushes your value modifier.
Mm-hmm.
The PQRS measures you choose will determine whether you're capable of pushing the meter forward on your QRUR report. If you look at those QRUR reports, it looks like a comet. And the head of the comet is where most of the practices are sitting, and there's this huge tail of practices that are getting dinged. There's almost nobody ahead of that head of the comet. And if you look at the GI measures that we report on, it is physically impossible to get a 1 standard deviation improvement over the mean. The IBD means are 99%. So you can only meet it. You can't exceed it. And so I don't think we ought to be focusing on the cost of what it takes to report, because obviously that is going to have to get fixed over time. But the science behind the calculation of quality performance is flawed, and we have to continue to work. You have to go through that list of PQRS measures, choose the ones that have the lowest mean, that gives you the best opportunity of, I know it's gaming the system, but you play the game with the cards you're dealt. And so look at the list of PQRS measures where the mean is low and you can be a standard deviation above.
Yeah, there's actually a follow on that. There's general internal medicine, surgery in the hospital, all of those. When you're in the green, you got to be 99%, and that's what everybody's supposed to be. If you're 93, you're red. It's so skewed.
Let's.
The only problem with that logic over is it's like buying the book, How to Get Through Walt Disney, before everybody else. How to Get on the Rise Before everybody else. And they say it's a 5 million seller. Well, if they sold 5 million, then no one's going to do it.
Right.
So our job here, of course, is that if this is perfectly through to our membership, well, it doesn't do us any good.
There's not that many of us here. We have a few years ahead.
Let's do one more question, and then we'll save them for the panel. But go ahead.
Just to comment,
Yeah.
I think that the question is not how much it costs to participate, but how much does it cost not to participate? That's
Yes.
the question going forward.
Yeah, there are avoided costs here if you participate, and we're going to hone in on that a little bit more here. So, the value-based payment modifier, as I mentioned before, this is going to be incorporated into MIPS, so it won't completely go away. But we don't know entirely what it'll look like. But at least for purposes of your 2018 payment update, what you report into PQRS is going to affect your value-based payment modifier going forward. So just a couple of things, starting in 2017, based on 2015 reported data, everyone will have the value-based modifier applied to them in that year going forward. It's been phased in up until then. One of the things you want to remember, and I'll break this down a little bit more, is that the initial penalties under the value-based modifier are predicated on your participation in Pqrs. So the moment you decide not to report into Pqrs, you are already putting yourself at risk for a penalty a certain penalty in the value-based payment modifier, and they're cumulative. So and the one last thing I did want to mention, just to remember, is that the value-based payment modifier is essentially a budget-neutral program. So you never really know what the bonuses are that are going to be available, because the bonus pool is dependent on how many people get penalized. So just to show you how this is going to work going forward, so based on 2016 performance, what 2018 adjustments look like. So if you decide not to participate in 2016 and you're in a group of 9 or less, you will automatically be administered a 2% penalty in 2018, and that's going to be in addition to the 2% penalty for not participating in Pqrs. So off the bat, you're at a 4% penalty. If you do participate in Pqrs, then you will be tiered on your performance. So if you're determined to be a poor performer, you could get a 2% penalty. If you're average, 0, and then high performers are going to get a multiplier. But again, since like I mentioned, you don't know what the bonus pool is, so you don't know how big those are going to be. For groups of 10 or more, there's a bit more at risk because they've been in the program longer. So if you don't report into Pqrs and you're in a group of 10 or more, you will automatically get a 4% penalty. And again, that's in addition to the 2% Pqrs penalty, so 6% out of the gate. If you do participate, there's the tiering again. So you could still be subject to the 4% value-based modifier penalty, but you've avoided the 2%, so you're still better off. If you're average, you're at 0, and then high performers get a multiplier. This was the tiering last year, but let's skip that. And basically, just here to show you how you're tiered, is you have the modifier amount that's going to be calculated based on your quality of care composite score and your cost composite score. And all of your Pqrs measures, in addition to a couple of additional ones that CMS runs, go into the quality of care composite score, and then there's a cost composite score too. The only reason I put this up here is not that you have to worry too much about it, but it's just to remember that it's your Pqrs reporting that goes into that quality composite. And while there is a lot of concern about the cost measures that are used, there's nothing that you affirmatively report in. So when you're thinking about your reporting burden, I would really focus on the Pqrs quality reporting piece of it, while the rest of us worry about how to get that cost thing right now. In 2015, this was last year, this was the first year that it was administered, the top 5 specialties included gastroenterology in terms of who got the bonuses. Now, one thing I do want to mention is that this was only applied last year to groups of 100 or more. So that's going to skew, I think, who's in the groups, or that might have more to do with who got the bonuses than the specialties, because I don't think that any of these were single specialties. And you can just see the number of specialists, number of gastroenterologists that were in groups that got the upward adjustment was a little over 4,000. But this is the key that I want you to take away from this, and then I'm going to highlight it again when we look at 2016 numbers. If you were in a group that got a downward adjustment, you got a downward adjustment because either you didn't participate, you didn't sign up, you didn't report into Pqrs, because you registered and you didn't meet the reporting requirements. So let's say you had to report on the 9 measures, you only reported 7, you didn't do it right, or you reported and you were actually tiered, and you were either determined to be high cost or low quality. And in CMS's experience report for the 2015 value-based modifier, they said for all the specialties that received a downward adjustment, that failure to register was the most common reason that specialists received that downward payment adjustment. So not participating is the easiest way to get this penalty. Just an example there, you can see in urology, it was of the people who were, of urologists, 30.9% received the penalty that were subjected to the value-based modifier explicitly because they didn't play, not because they submitted data and were determined to be high cost or low quality. That was only 0.7%. If you look at 2016, we don't have specialty-specific data yet, but CMS just released this information either this week or last week. A couple things I want to mention. There were 13,000, almost 14,000 physician groups of 10 or more that were subjected to the value-based payment modifier, and again, this was based on 2014 performance. About 8,300 met the Pqrs reporting requirements, and they were subjected to the tiering of the value-based payment modifier. About 59% are going to receive a neutral adjustment. So most people are just going to be at zero. 0.9% are going to receive an upward adjustment, and you can see that based on the bonus money that was available, they're not insignificant, 15, almost 16%, and over 31%. But here, you can see that only 0.5% received a downward adjustment. And again, that's 0.1%, or I'm sorry, 1 or 2% was the downward adjustment based on group size, but it's only 0.5%. So it's not like you have an influx of people who are reporting into the system and then getting hit over the head with a penalty. Part of that has to do with the benchmarking and standard deviation, but the most important, I think, takeaway is that 5,418 of those 13,000 groups, it's almost 40% of the practices, got that automatic 2% penalty because they didn't meet the minimum PQRS reporting requirements. So the surest way to get this penalty is to not report into it. So I know that, and I don't want to make light of the meaningfulness of the measures that you have to report on, but I do want to highlight that to the extent that the finances are playing into this, that by not reporting into it, it's the surest way to get a penalty. And again, for those that received that 2% penalty, a lot of them also just didn't participate in PQRS at all, so it's really a 4% penalty. Here in the last couple of slides, I just want to show you where we are these last couple of years. So again, in 2018, which is essentially the year we're in, if you look at the cumulative penalties by not participating in the value-based payment modifier, PQRS, or achieving meaningful use, you're potentially on the hook for 10%. So these numbers are starting to add up. That levels out a little bit as we talked about with the first year of MIPS, where we move into essentially a plus or minus 4% range. But there's real money on the line here in 2018. And again, I just bring this timeline up to reiterate that we're essentially already in 2018. So with that, I would normally stop and ask for questions, but we're going to have a whole panel on this now, and I know that we probably went a little bit over. So why don't we have the panelists come up